Today, we would like to discuss some ankylosing spondylitis. Last time we looked at the uh, rheumatoid arthritis. These are very competitive diseases. In clinical practice, these will come very often. Polyandromic rheumatism, some other rare varieties you don't get any time. What you get is rheumatoid arthritis, osteoarthritis, ankylosing. If you are through with these things, thorough with these things, it is enough for you. So, let's see the ankylosing spondylitis is, first of all, we should know what we are talking about. So the definition of that ankylosing spondylitis is, it is a chronic disease. It is a systemic illness. It is an inflammatory disease. It is a disease of the axial skeleton. And variable involvement of the peripheral joints and non-articular structures. Lot of non-articular manifestations are there. Something like a systemic disease only, it will be presented to you in various ways. So chronic, inflammatory, systemic, axial skeleton, peripheral joints, rarely involved, non-articular also. It is one of the seronegative spondyloarthropathies. Means if you do a rheumatic factor, it will be negative. So that is called seronegative arthropathy. Seropositive is RA factor positive, seronegative. The commonest joint involved is the sacroiliac joint. We have two sacroiliac joints, one on either side. It may start. I had a patient in this institution. Young man is computer science specialist, working in a software company, came with back pain. When we looked at the history carefully, it turned out to be ankylosing. So there are certain other names, because what happened is one of the examinations, write a short notes on Mary Stumple disease. The people did not write, many people. They knew ankylosing spondylitis, but they did not know that this is that. So they came back and asked me after the examination, sir, question paper says we did not answer. Why? Did you know no ankylosing? Yes, we know. So that is what they have asked. But you should know the alternate names also. They may suddenly ask Mary Stumple disease or Wethrow Mary Stumple disease, whatever it is. Okay? The prevalence, as you see, it is more a disease of the Caucasian race, the Europe, the Northern America, American part, the Russia, and those things. That doesn't mean that we don't have it. It is not a very great disease affecting the Africas and India and South America. More a Caucasian race environment. So what is the etiology? Etiology of most of the autoimmune diseases is not known. Here also it is not known. But there is one great marker called the HLA-B27. HLA-B27 antigen is a genetic predisposition for the ankylosing spondylitis. Okay? So bacterial infections like Klebsiella, etc. are involved in this particular disease, particularly urinary tract. Urinary tract infections with Klebsiella can predispose to ankylosing spondylitis. So what did we learn till now? You tell me. What are the things we learned? It is a chronic disease, systemic disease, axial skeleton, progressive disease, multi-system involvement, non-articular manifestations are there, also called Mary Stumple disease. HLA-B27 is the important marker that I should remember. Urinary infections like Klebsiella can be a reason for having ankylosing spondylitis. Okay, so I will be summarizing now and then. So you should, what is HLA-B27? Definitely, this itself is a short notes. Write short notes on HLA-B27. Then you should know human leukocyte antigens. These antigens are on the leukocytes. It is on the B27 locus. It is a surface antigen encoded by the B locus of the MHC. MHC is major histocompatibility antigen. This is on which chromosome? Chromosome number 6. Okay, there are antigenic peptides to the T cells. So what they will do? There is an antigen called HLA-B27. It is on the chromosome 6. There are A locus, B locus like that. there is a B locus. It is the major histocompatibility antigen, and this produces antibodies against the T cell. And these T cell antibodies will go and damage the joint. It lies on the surface of the WBC. HLA-B27 is strongly associated with ankylosing spondylitis and other associated inflammatory diseases called the spondyloarthropathy. More than 100 disease associations are made with HLA-B27. We cannot give the list of that here, but suffice to know that HLA-B27 is the marker for ankylosing spondylitis. Okay. What are the associated pathologies? Ankylosing HLA common things out of the 100 things. What are the 5 or 6 common things where HLA-B27 will be positive? Number 1, ankylosing spondylitis. Number 2, JRV, that is juvenile rheumatoid arthritis. Number 3, arthritis of Crohn's disease and ulcerative colitis, that is called the IBD associated arthritis. Inflammatory bowel disease associated, psoriatic arthritis, reactive arthritis also called the Reiter syndrome, and uveitis without joint involvement also can have B27. I am summarizing again. Ankylosing spondylitis, juvenile rheumatoid arthritis, IBD arthritis, psoriatic arthritis, reactive arthritis, and uveitis. So how do we do this test? It is a laboratory test which is done using the serum. The serum we will take and then look for the HLA-B27 immunogenetic PCR blood test, something like your PCR test only, but it is a more an immunological test. Venous blood is used. Patient should not smoke for 1 hour before the collecting the blood. The price you leave it. It costs around 2,000 rupees here in this hospital. Differential diagnosis of systemic diseases, it is indicated very much. An additional test which helps to validate a diagnosis of ankylosing spondylitis, and this is not the main investigation. Don't think that HLA-B27 is the test. If that is positive, ankylosing spondylitis negative, not. We have a plethora of clinical manifestations. On the support of it, HLA-B27 occurs. Because this test is negative in 10% of patients with ankylosing spondylitis. Okay. Enterobacteriaceae. Enterobacteriaceae, what are they? Salmonella, Escherichia, Yersinia, Klebsiella. These are gram-negative enterobacteria. Okay? Mostly urinary pathogens. These can be triggers for the ankylosing spondylitis. So what is the pathogenesis? 2 theories are there. Receptor theory, molecular mimicry theory. What is the receptor theory? HLA-B27 is a receptor for this bacteria. So what this bacteria will do? The bacterial antigens will go and interact with HLA-B27 and produce the T cell cytotoxic antibodies and thereby producing the T cell. That means the bacterium, bacterial antigen, HLA antigen, they combine and then produce antibodies against the T cells and then produce cytotoxic antibodies. That is one mechanism. It could be urinary or bowel because enterobacteriaceae are present both in the bowel and the urine. Molecular mimicry theory. This says the bacterial antigen or the damaging factor of the bacteria is looking like HLA-B27. It mimics the HLA-B27 and the body prepares an antibody for B27. This because the bacterial antigen looks like B27, body by mimicry, because it is mimicking it, body mistakes it and prepares antibodies for that. And those antigen antibodies are HLA-B27 and the human antibodies, autoimmune antibodies, go and damage the T cells. That is called the immunological tolerance. So 2 theories are there. Molecular mimicry theory and then receptor theory. What is the pathogenesis? It is autoimmune disease already we said. It is an inflammatory disease also we said. What is inflamed? The inflamed part is the sacroiliac joint and intervertebral and costovertebral joints. What are the organs affected? Sacroiliac joint, intervertebral joint, costovertebral joint. What is costovertebral joint? This is the costa, the rib. The rib goes and joins the vertebral column. That is the point. So not the chondrovertebral joint. Chondrocostal joint. Chondrocostal joints are here. Sternal cartilage and this. This is costovertebral joint on the back. Okay. Characterized by active fibrosis and further it is called ossification. In fact, ankylosis means ossification. The word ankylosis means it is ossification. So pathomorphology. actually what happens in the joint. There are 4 changes that occur. Enthesitis, synovitis, osteitis, and ankylosis. Enthesitis, what is enthesium? Enthesium is where the ligament goes and attaches to the bone. Each muscle has a ligament. The ligament, for it to work, it should have a handle, a fulcrum, a place it is stuck. That place is called the enthesium. And that enthesitis means again the muscle function will be affected. Subchondral granulation tissue will be formed using macrophages, lymphocytes, and all. Second thing is there is synovium in the joint, just like rheumatoid arthritis. This is also a synovitis. There is a pannus formation, new blood vessel formation is there. There could be osteitis also, the bone infection also can be there. Finally, there could be fusion and then ankylosis. Okay. So you see the normal spine on the left-hand side, beautiful blue intervertebral discs are there. The vertebral bodies are very good in shape and there are no osteophytes. There are no projections here anywhere in the edges of that. The second one you see, there is inflammation of the synovium and there is also the intervertebral discs are thinned out and there is projections of the bones that occur. Finally, you can see the projections are fused there in the last slide so that there is an ankylosis of fusion occurs. This is called the pathomorphology. Then, sites of affliction. As we have already told, sacroiliac joints are the most common. The second one are the intervertebral joints, brachial joints, shoulder joints, cox of femora, hip joints, knee joint, ankle joints, and finally the small joints are. Whereas rheumatoid arthritis, small joints start with very rarely large joints, never others. Whereas this is more of a spine disease and less of a peripheral joint. More an axial skeleton, not appendicular skeleton. Sacroiliac joint, intervertebral joint, osteovertebral joints, brachial shoulder joints, cox of femora means hip joint, knee joint, ankle joint, and other small joints in some cases. Okay. What are the manifestations? Symptoms of early ankylosing spondylitis. Not an advanced ankylosing spondylitis. Early ankylosing spondylitis is you have to be very early, you have to pick up the disease because you have to start the disease modifying agents for them. So for that reason, we require to know the early manifestations. Pain in the sacroiliac joint or low joint. You can see the pain area there, the red area there is the pain area and worsens at night and in the morning, nocturnal pain, mostly nocturnal pain. Relieved with motion and in the act. Or the patient says, sir, I have back pain. Do you have it when you are working? No. Do you have it immediately after getting up? Yes. Do you have it in the night? Yes, that night it is terrible. When I go for work, no. Whereas osteoarthritis, it is when you are resting, no pain. When you are working, pain. That's the difference. Okay. Buttock pain. It radiates into the posterior surface of the hip joint and migrates from left to right gluteus or right to left gluteus. Okay. Next one, lower back stiffness. You will say, back is stiff and I'm not able to bend the back, particularly for about half an hour in the morning. Relieves with anxiety. Okay. Or if he takes a shower, he feels relieved. Another important thing is it mimics myocardial. Chest pain, it can come. So it mimics intercostal neuralgia, intercostal muscle myositis, worsens. First one is pain in the sacroiliac and lower back, as you can see there. Second one is the buttock pain. The third one is the lower back stiffness. Fourth one is intercostal pain, like chest pain, worsening on coughing and sneezing. And the fifth one is the stiffness and tenderness of the back muscles and flattening of the lumbar lordosis. And finally, bilateral sacroiliitis. And of course, enthesiopathies, and then extra-articular management. What is the most common extra-articular gland area involved? Eyes. The uveitis, the anterior uveitis is very common. It could be bilateral, it could be acute. It can last for a couple of months and it is very, very painful and registered in about 30% of patients with ankylosing spondylitis. They have the eye disease. Sometimes the presenting area is ophthalmology. They go to the ophthalmology, present with uveitis. They treat for uveitis with antibiotics and anti-inflammatory drops and all. It is not regressing. Then they will refer to the physician. We find out. Okay, that's also it. Okay, now. Advanced AS. Earlier we have talked about early AS. Now advanced AS. Pain in different segment of the spine, question mark posture, atrophy of the muscles, decreased thoracic expansion, decreased articulations in the spine, ankylosis of the sacroiliac and intervertebral joints, cutaneous lesions also. I will show you. It will be like pustular psoriasis. I will show you that. Cardiovascular symptom involvement, particularly aortitis, aortic insufficiency, pericarditis, myocarditis. These are the cardiovascular manifestations. This also happened in one of my cases earlier days, around 20 years back. Patient came with aortic regurgitation. And we have diagnosed aortic regurgitation. We are doing all the things. In those days, echocardiography and all were not there. Only by X-ray chest and then percussion and all sorts of crude methods we used to say there is cardiomegaly and then heart failure and aortic regurgitation with murmur and all. But when we evaluated, that fellow has ankylosing spondylitis. Bronchopulmonary involvement, urinary system involvement, gastrointestinal, particularly inflammatory bowel disease. These can happen. Now, what is that question mark posture? You see, this is a normal individual on the right hand side. The question mark, on the left hand side. In between, the patient stands also like a question mark. That is because of stiffness of the spine. Lumbar lordosis is lost. The back is bent and he is bending forward and the neck is extended like that and he stands like that. So here there are certain tests which one of you have to volunteer for that. You can see this is the question mark position. This is an extreme advanced AS. We should not wait to get a patient to this stage and then think, oh, it could be ankylosing. Anybody will tell, patient himself will tell, my spine is frozen, sir. I am not able to stay. That is ankylosing. Ankylosing is what? Frozen spine. He himself will tell. No, they don't require an MD physician to diagnose. Now, this is another short note question. What are the extra-articular manifestations of AS? 1. Ocular, anterior uveitis, cardiovascular, aortitis, myocarditis, AV block, gastrointestinal, colitis, enteritis, particularly inflammatory bowel disease, cutaneous, pustular psoriasis, pulmonary fibrosis, renal amyloidosis. We'll go one by one. We will see these manifestations. Ocular, cardiovascular, gastrointestinal, cutaneous, pulmonary, renal. Means what? This is a multi-system disease. It is not a ankylosing spondylitis. Oh, this is a joint. No. It is a disease of the whole body. Joint is one area of man. Okay? Now, that's how uveitis is. Anterior uveitis, iritis, iridocyclate is an inflammation of the front part of the eye between the cornea and the lens. What is uvea? Uvea is iris and then the iridocyclate appears in 30% of cases of EAS. Symptoms: eye pain, photophobia, redness, blurred vision, spots in the field of vision. Usually resolves within 2 to 3 months without residual visual impairment. That's important. Whereas when you have uveitis due to tuberculosis, due to other causes, there will be residual scarring. Here there is no residual scarring. Complications: hypopyon can occur, synechia, that is attachments can occur between the iris and the cornea, cataract can form, glaucomas can form, and treatment: steroids, antibiotics, and mydriatic drops, and usage of sun protective glasses. So as far as the eye is concerned, uveitis, anterior uveitis, iritis, iridocyclitis, very painful, photophobia, and then lacrimation. And then it is a short-lived 2 to 3 month release. Whereas in case of cardiovascular, aortitis, aortic insufficiency, pericarditis, myocarditis, AV block occurs in 30% of 33% of cases. Investigations: do the cardiac investigations. All these conditions should be treated by the cardiologist. Gastrointestinal manifestation: inflammatory bowel disease, chronic disease. Disease spelling is mistake. Chronic inflammatory Crohn's disease ulcerative colitis. Okay, and diagnosed around 5 to 10%. So 30% will have eye problems, 30% will have cardiac problems, 10% will have gastrointestinal problems. So what are the things? Abdominal pain, vomiting, diarrhea, bleeding, internal clamps may be there, weight loss, anemia. Complications, toxic megacolon, bowel perforation, colorectal cancer, intestinal obstruction, fistula formation, abscess, all complications of chronic inflammatory bowel disease. Okay, investigations. How do we find out gastrointestinal involvement? By doing a colonoscopy, biopsy, and stool exam. Treatment, steroids, immunosuppressant. Now, cutaneous manifestation. Cutaneous, you see the lesions, they are like pustules, small pustules. One may mistake for pustular lesions. Psoriasis is a chronic inflammatory condition and maybe 5 types: flaky, gutted, inverse, pustular, erythrodermal, of which pustular psoriasis is common with ankylosing. Psoriasis itself presents as 5 types. Flaky, the flaky white flakes will be coming there. And Jenk's sign will be positive. Gutted psoriasis, inverse psoriasis, pustular psoriasis, erythrodermic. This occurs around 1/4 of the patients. So we require that. You can see the various methods. You see, they look as though they are typical psoriatic lesions. The underlying thing is the ankylosing spondylitis. Okay. Pulmonary, we have already said fibrosis, apical lobe fibrosis can occur. Fibrosis is due to tuberculosis also. You must always exclude in this country any fibrotic lesion. You have to exclude tuberculosis. Symptoms, productive cough or non-productive cough. 50% of the patients will have lung manifestation. Now, 30% ocular, 30%, cardiovascular, 25%. 10%, by inflammatory bowel disease, and 25% will have skin manifestation, and 50% will have lung problems. The spirometry values will be much lower. The FVC is reduced, and then the FEV1 also is reduced. Okay. What are the renal manifestations? Amyloidosis and immunoglobulin A nephropathy. And finally, complications with a chronic renal failure. So what are the various complications? Functional insufficiency, spinal fractures due to osteoporosis, cauda equina syndrome. One day we should discuss cauda equina and conus medullaris, because you will get a long case. Cauda equina cases, there they will get it. So you should very clearly know what is cauda equina and what is conus medullaris. Probably we will have that in the coming months someday. We'll take it. It's a nice lecture is there. You should know the anatomy also. Before that, what you have to do is you should be familiar with the anatomy of the cauda equina region and then come prepared. Then we will discuss. Okay. So, the forms of the disease are, it can be classified as central SPAS. That means spine and sacroiliac joint. Rhizomelic, that means it takes the spine as well as shoulder and hip. Peripheral, more distal joints. Scandinavic, spine and hand joints. Hand joints and spine involved, it is Scandinavic. Visceral affects joints and the internal organ. From here, it is very important for you clinically to diagnose it. Either to the priming symptoms, complications and various systems involved and all that. Here, lumbar mobility tester. Nobody will teach these things, I am sure. If you have to go to orthopedics to learn this. Only orthopedicians might be telling, but physicians, they will never do this. But it is for you to know this. Lumbar mobility, thoracic mobility, cervical mobility, hip mobility. The 4 areas have to be tested. First, on the lumbar mobility, we have 3 tests. Modified Schober test. Finger to floor distance, Tomeyer's test. Lumbar flat flexion test. Okay, come here. So this turn back. So what I will do is, this is the sacral joint. Okay. So I am focusing on the lumbar spine. Take a measurement from here to the sacral joint and ask him to bend. Bend forward. What will happen? The tape will move forward and will have a long. In a patient with ankylosing spondylitis, this moment will not be there. Okay? Schauber's test. Two marks are made on the patient's back, one at the level of the sacral dimple, where the sacroiliac joint is there, that is the fifth lumbar spine, and the other 10 centimeters above that. You make two marks. Now, when he bends, these marks will go away. The mark normally is 10 centimeters, I have marked. When you bend it, the skin stretches and you go forward, becomes 15 or 20, depending on how much you have bent. In this patient, it will be very little. This is very simple test. You don't require a PET scan or an MRI. This is called Schauber's test. Patient then bends forward as far as possible, attempts to touch the toes with the knees extended. To that extent, you should try to bend. And the distance between the two marks is again measured. Normally, at least 5 centimeters, it should increase. If it is not increasing, it means it is Schauber's test positive. Means what? Lumbar mobility. Here, what I am testing? The mobility of the lumbar. What is Schauber's test? I have shown. Okay? Take from the dimple of the spine, the fifth lumbar spine, and then 10 centimeters above, you make a mark, and then ask the patient to bend forward as much as he can until he can touch the floor. This patient will not be able to touch, but maximum movement. Then what will happen? Normally, there must be 5 centimeter displacement. What you have put 10, these two marks will be 15 centimeters. In this fellow, it will be less than 10, 5 centimeters. Less than 50. Okay? This is modified Schauber's test. Little different. This test marks are made 5 centimeters below and 5 centimeters above, 10 centimeters above the sacrum. Instead of doing one marking above, 5 centimeters below also one more marking we have made. The distance between these marks should increase from 15 to 20. Same thing only. Now what we are doing is we are allowing. So for lower spine also we are allowing. Okay. So the distance less than 5 centimeters is abnormal. Then finger to floor test. Come in. Here, ask the patient to bend forward and touch the toe. He is able to touch. Some people, even sometimes elderly person, they will not be able to touch. The tips of the fingers to the floor, you measure the distance. That is called finger to floor distance. Okay? The measured distance is between the tip of the finger and the floor when the patient is bent forward with the knees and arms fully extended. That's important. So while bending, you should not bend the knees. Keep the knees straight, arms also not like this, fully stretched. That's called finger to floor test. What does it test? It tests lumbar mobility. We are in the lumbar region now. Then we go to thoracic region. So lumbar region, what is the first test? Schauber's test. Second test, modified Schauber's test. Third one, finger to floor test. Then lateral lumbar flexion. You come in. Stand close to the wall as they are touching. Where is the mark is under the hand here. Okay. Now ask him to, you bend this way as much, slide your hand as much as you can. See, from here, come up to here. Whereas the person with ankylosing spondylitis, because the flexion mobility is completely restricted, the finger at best will go only 1 to 2 centimeters. They will not be able to reach them. This is called lateral flexion. Schauber's test, modified Schauber's test, finger to floor test, and then the lateral flexion test. Very simple test. These don't require any great expertise. Any person with a little bit common sense will understand. And only thing is you should remember to do those things. The moment is B27. Before B27, whether you just clinically examine the patient or MRI spine. That's not required here, MRI spine. Or even X-ray is enough for this. We don't require an MRI spine. Okay. Now we have come to the thoracic region. In the thoracic region, chest expansion is measured. So all of you 5 centimeters minimum between inspiration and expiration because of the chest excursion. Minimum of 2 inches, which is 5 centimeters. In centimeters, it's 5 centimeters. And normal expansion is more than 5 centimeters. These persons will have 1, 2, because the chondrovertebral joints are fixed. The costovertebral joints are fixed. where the rib is attached to that, it is not able to move. So it's not expanding. So the costovertebral joints are fixed. That is why chest expansion is reduced. And there is fibrosis also inside. So both of them are contributing. Lung fibrosis inside and then joint fixation of the posterior joints of the spine. Okay. Important test, which is called the cervical test. On chest, for thorax, only one test, the expansion test. For this one, come in. When he stands like this, he is this head can touch the. It's normally when I stand, my head should touch the occiput should touch the wall. In ankylosing spondylitis, because of the posture like that, and he will not be able to touch the, and there will be a distance between the head and the wall. This is called wall occiput relation. Okay. The other thing is this is called the tragus of the ear. Okay, the little projection there. And the distance between tragus and the wall. That also is same. Wall occiput distance or tragus occiput distance, tragus wall distance. So, for position, patient should keep his hands and one like this. Hand erect, try to bend the neck and touch the wall. Only we should be able to touch most of them. Only elderly people slight 1 centimeter may be there. But if these people, they have normally 0 should be the distance. But here the distance between the wall and the occiput is very much removed because of the bent posture. This is called occiput to wall distance. Okay, occiput to tragus distance is measured here in the table. Tragus to this one. So tragus wall distance, normally 15 centimeters, less than 15 centimeters. If it is more than that, it means it is ankylosing spondylitis. Now repeat that test. For the lumbar mobility, Schober's test, modified Schober's test, floor to fingers test, and then lateral flexion test. For thorax, chest expansion. For occiput, wall occiput distance, tragus wall distance. Wall occiput distance should be normally 0, tragus should be less than 15. If anyway, these two are abnormal, patient has got a spondylosis, ankylosing spondylitis for the cervical spine. Another important test is cervical rotation test. So you can see, why does it go? Pushing the other way, yeah. See here, there is one small meter-like thing is there. You keep it on the forehead and it registers 90. And you keep it there, it is like this now. And ask the patient to turn the head to the right or left side. Then this 90 should become 45 or like that. The 0, 95. 0 is left. So 90 is there when the patient is dead. Okay, 0 degrees, 90 degrees. 0 degrees, 90 degrees. But in this patient, because he is not able to do the rotation of the cervical spine, this rotation towards left and right is compromised. They'll have 10 degrees, 5 degrees, 15 degrees like. Normally, you should be able to do around 80 degrees of rotation. A young man can do it. An elderly person like me will be able to do 77, 65% of the rotation of the neck. This is called cervical rotation test. This is called the goniometer. Very big name. What is goniometer? A simple camphor like thing where the needle moves depending on the tree. That's okay. Patient is supine, head in neutral position, forehead arch. Necessary head pillow or foam block to allow this. So you can allow a little pillow also so that he will be able to comfortably rest the head, and in pain he will not be able to rotate. So because particularly these patients, this distance is very much increased. So a pillow is essential for them because their wall occiput distance is almost very much more than normal. So they have to have a pillow. As far as possible, he rotates. Normally we expect 70 to 90 degrees. The people should be able to do up to 90. At least I should be able to do up to 70. These fellows will not be able to do that. Then intermalleolar distance. Okay, stand here. Keep your feet as wide as possible. As wide as possible. Without, you can lean on the back also and then up. Enough. And then measure this malleus to that malleus. What is there? That person will not be able to do it because the hip joint mobility is restricted. Intermalleolar distance normally is more than 100 centimeters. Intermalleolar distance should be at least half of the height. Height is 160. Intermalleolar distance should be at least 80. But height is 180, 90, 100 also, more than 100, minimum, at least more than 100 you should. Okay. So this patient, the intermalleolar distance is very much compromised. The legs cannot be separated as we separate. Okay. So that is the intermalleolar distance. This again tests the mobility at the sacroiliac joint and the hip joint. Sacroiliac and hip joints are tested. Test for sacroiliitis itself. Is there inflammation of the sacrum? Now you summarize the test. So Faber's test, modified Faber's test, Schwaber's test, modified Schwaber's test, lower to finger, this one, lateral flexion, thoracic expansion. Then comes the pole occiput, tragus occiput. Then rotation, goniometer. After that, you have the intermalleolar. All these are mobility tests. Here we have not tested inflammation. We have tested the mobility part. Now, what am I testing now? I am testing whether there is inflammation in there. Where is the inflammation commonly? Sacroiliac joint. So, test with sacroiliac. This is called pelvic compression. Unimportant thing. Faber's test and Jensen's test. These nobody teaches you unless you have a teacher who is interested to tell you these are the things. You have to learn these tests. How do I do that? You see that patient. I will describe because he can't volunteer on this table. You require a coach. So the patient is made right lateral first and then the left lateral. Patient is dead lateral on the right side with the knees extended, hips extended, ankles semi-flexed. Okay? Arms can be loose. Now the examiner, what he is doing, he is giving a pressure on the trochanter, greater trochanter. On the greater trochanter, compress the pelvis with the patient in the prone position. That is in the lateral position, not prone position. Sacroiliac pain will be lateralized to the inflammation. Pelvic compression, two parts are there. One part is patient is laying prone, completely prone, and you give a pressure on the sacrum. And whichever side is inflamed, the pain will be on that side. Both sides are normal, there is no pain on either. The other test is lateral compression. Make the patient lie down like this, give a compression on the trochanter there. If the pain is on, now you see, when the pain is there, when you are pressing on that side, it means it is this joint is affected. When it is the opposite side, it is the other joint. Then repeat the test onto the right lateral left. So pelvic compression test has got three positions. Supine position, right lateral, left lateral. Supine position compress on the sacrum and then localize the pain. And this one, you compress on the trochanter and then see which side the pain. This is called pelvic compression test. Now, you have got this is that position. Okay. Now, this is Faber's test. That is Schober's test. This is Faber's test, also called figure of four test. So ask the patient to lie down, hip extended, right leg, left leg, knee also extended, and try to ask him to fold the right leg onto the knee joint like this, like figure of four. Normally, one should be able to do that. This is also called Patrick's test or figure of four test or Faber's test. Okay. It is performed by having the tested leg flexed, abducted, and externally rotated. So what is the tested leg? Right leg is the tested leg because it is extended. Leg is flexed, abducted, and externally rotated. If pain occurs anteriorly on the same side of the body, it is a hip joint disorder. Very important. Whether hip joint MRI you want to take or sacroiliac spine you want to take, this. Now what you are doing, ask the patient to lay flat, one leg completely stretched, left leg, right leg he flexes and then abducts and then external rotates and figure of four like thing he keeps. By doing that, you give a pressure on the testing leg knee joint. You are now pressing on the knee joint. The examiner is pressing one hand on the knee joint, one hand on the ilium. Left ilium and right knee joint are the two hands. The examiner is pressing. If there is pain anteriorly on the same side, on the side you are examining, the right side in this case, it is hip joint. If you feel the pain on the opposite side, it is sacroiliac. You have to repeat. Okay? Faber's test. Then Jensen's test. Jensen's test is very simple. As the tested leg, the non-tested leg is extended, or it can even drop off from the couch also, like that. Or you can keep it extended. The tested leg is he keeps like this and then pulls it towards the body. The examiner places one hand on the anterior thigh of the non-tested leg and the other hand on the knee joint of the tested leg to apply a pressure, a flexion over pressure. It tries to forcibly flex the hip joint. The extended leg may also be placed off the table to create a greater force. That's what it is done here. A positive test occurs if it produces low back pain. Normally, this movement should not cause pain in the low back. Okay, that is called Jensen's test. Now, you have to review the tests. Pelvic compression test. There are compression tests, pelvic compression test, and then the supine position, prone position, lateral position. And then you have the Faber's test, and then finally you have got the Jensen's test. So these are tests of sacroiliitis. So what did I do? I classified the test into two types. Those related to mobility, those related to inflammation. And already we have reviewed those. Now comes the labs. What are the tests I do? CBC, increased ESR, sometimes hypochromic anemia, chronic disease anemia may be there, leukocytes. Biochemistry, increased levels of alpha-2 globulins and gamma globulins, seromucoid, sacroiliac acid, and then CR. Rheumatoid factor, usually negative. Seronegative spondyloarthritis. HLA-B27, 90% positive. Others, depending on the extraarticular manifestation, you test gastrointestinal or take an X-ray just for fibrosis or do an echo for the aortitis and then aortic regurgitation and all those things. Or you do a stool examination and colonoscopy for the GI involvement, or look at the skin for the dermatological manifestations, or look at the eye for the uveitis. These are the other tests. Okay. So, what are the test imaging I want? X-ray is the main diagnostic method, not MRI, not PET scan, anything. Take an X-ray of the sacroiliac spine. Scintigraphy, CT scan, MRI, depending on the necessity, particularly to exclude other diseases, you may do them, but not to confirm the disease. Now I will show the X-ray picture. You can see here, this is a normal spine, a sacroiliac joint. A B is the grade 1, A is the suspicious, 0 is normal. This is where 0 is normal. Grading is the grading, 0 is normal, and then X-ray grading. 1 is the A picture, suspicious. B is the minimal sclerosis and some erosion. C, you can see the C picture here, and that is the more advanced definite sclerotic lesions. And finally, the grade 4, the complete ankylosis. The last picture, you don't see any joint there. Completely it is fused. The ankylar joint is ankylosed. This is also called bamboo spine. Why? Because it is like a stick. The spine has got no flexibility either this way or sideways. It's called bamboo spine disease. Bamboo spine occurs as a result of vertebral body fusion. This is a body, this is a body. Between them, there are osteophytes are formed. These osteophytes are like this, like a mesa, like the mustache. Then they join. Then they are fixed to one. Marginal syndesmophytes, often accompanied by fusion of the posterior vertebral elements as well, typically involves the thoracolumbar and lumbosacral joints and predisposes to unstable vertebral fractures. Okay. You can see that outer fibers of the annulus, all the description you leave. Look at that picture. Normal spine, There is lumbar lordosis is there, curve is there, and you can see the intervertebral bodies and the discs are there, vertebral bodies, intervertebral discs are there. But here you see the intervertebral disc height is lost. There is anterior fusion, endosmophytosis is there, and then they are now become like a straight line. They have become fused. Okay, so there are certain signs. Now, how do I grade? 0 is the two vertebral things are separated, and there is a gap between the anterior margins of the upper vertebra and lower vertebra. Below only one sclerosis, squaring, two syndesmophyte, and three complete bridging. Lastly, complete bridging. Now, just like the rheumatoid arthritis, we have got you the New York criteria of 1984. Clinical criteria, radiological. Low back pain for more than 3 months, improved by exercise, not relieved by rest. Whereas back pain of osteoarthritis will increases by exercise and relieved by rest. This is the other way. How to differentiate OA and that. Limitation of the lumbar spine movement and sagittal frontal planes as tested now all the tests. Limitation of chest expansion relative to the normal agents. Radiologically, sacroiliitis of grade 2 or more and sacroiliitis 3 to 4, one side. Bilateral grade 2 or more or unilateral more 3 or 4 grade. Definite age if radiological criteria present plus at least one other clinical criteria. Possible age, 3 clinical criteria, radiological criteria present, but signs and symptoms do not satisfy the clinical. Now, sacroiliitis on imaging and more than one SPA features. Inflammatory back pain, arthritis, ananthitis, uveitis, dactylitis, psoriasis, Crohn's, ileitis, good response to NSAIDs, family history of spondyloarthropathies, SPA is spondyloarthropathy, HLA B27, elevated CR. These are the sacroiliitis on imaging plus more than one spondyloarthropathy feature. What is spondyloarthropathy feature? Inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, and then psoriasis, inflammatory bowel disease, response to NSAIDs, family history spondyloarthropathy, HLA-B27 positive, elevated CR. More than one should be there. B27 positive and more than 2 SPAs are there. There is no radiological change. B27 is positive, more than 2 SPA features are there, then also it fits into AS. Active inflammation on MRI highly suggestive of sacroiliitis associated with SPA. Definite radiological sacroiliitis according to modified New York criteria. ASA, and that is AS criteria. Okay. Now, how do I treat this patient? Because I am doing all this to treat him. My ultimate job is to get him better. So, regime, drug therapy, physiotherapy, surgical treatment. Drug therapy, NSAIDs, steroids, disease-modifying anti-rheumatic drugs, anti-TNF drugs. 4 classes are there. Pain relievers, NSAIDs, steroids, DMRD, disease-modifying agents, and then the antibodies. That is anti-TNF drug. So the regimen means regular exercises. The best exercise for ankylosing spondylitis would be swimming or yoga, and contact sports are not allowed. Like football, where this fellow's mobility is limited and he will fall and get fractures. So contact sports are not allowed. Hard bed is prescribed because the already spine is frozen. If you give a soft bed, it sinks, and further, ankylosis will take. Posture, not only for him, even for us also, this is the position. How I am sitting, not like this, not like a monkey. Okay, you're supposed to sit, go as much back as possible, stretch your back, lean slightly, sit erect, and then take deep breath. Never the time in between twice. It's normal. Diet rich in calcium. Avoid, of course, overweight. This is general medicine. Regime means general medicine. What are the NSAIDs? Indomethacin is the first drug of choice. In ankylosing spondylitis, we use indomethacin, diclofenac, ibuprofen. Okay, these are the 3 drugs. Steroids only for the when NSAIDs are not effective, Then short course of prednisolone, 5 to 60 milligrams or 1 milligram per kilogram body weight. Suppose is 70 kilograms, 70 milligrams. 50 kilogram lady, 50 milligrams. Generally, it is a disease of men. It is not, it's very common in women. Hydrocortisone also you can. There is also called pulse therapy. That means prednisolone IV 1000 milligrams one time per day for 3 days. What are you looking at the phone? Keep it on the pulse therapy. Okay. DMRDs. DMRDs are extremely effective in case of peripheral forms of EAS. Central forms of EAS, they are not that effective. Sulfasalazine, methotrexate. First drug to be chosen is sulfasalazine. Sulfasalazine, 2 to 3 grams per day. Methotrexate, 7.5 to 20 milligrams, one time per week. Just as I told you last time, don't just give 5 milligrams or 2.5, useless. Minimum in rheumatoid arthritis 10 milligrams. Here minimum 7.5. TNF inhibitors. These are the biologicals. Tumor necrosis factor inhibitors, pharmaceutical drugs suppress the physiological to the TNF, and which is a inflammatory process marker. Advantage: highly specific, very selectivity, decreased risk of immunosuppression. Disadvantage: cost is very high, and oncological risk is also there. Global market for TNF inhibitor from 2003 it was 13.5, and in 2009, 2008, and now in 1 year it went to 22 billion. Now it may be 1 trillion or even. Now TNF inhibitors are used left and right for most of the inflammatory diseases, autoimmune diseases. So, indications: rheumatoid arthritis, ankylosing spondylitis, IBD, psoriasis. These are the 4 conditions in which we use the TNF inhibitors. RA, AS, IBD, psoriasis. Side effects can cause lymphomas, infections, congestive failure, demyelination, lupus-like syndrome, induction of autoantibodies, injection site reactions. What are the drugs we have? Golimumab. Golimumab subcutaneously every month, 50 milligrams every month, once in a month. Simponi, the brand name is Simponi. Adalimumab or Humira. Humira is the adalimumab or Exemptia, 40 milligrams one time per 2 weeks. Infliximab, golimumab, adalimumab, inflix. One of these things can be chosen. Doses also are. Is there any surgical treatment for ankylosing spondylitis? Yes. You would have heard in your MBBS Smith-Peterson osteotomy. They would have told in orthopedics, SP or SPO. Smith-Peterson osteotomy, pedicle subtraction osteotomy, vertebral column dissection osteotomy, VCR, PSO. These are some spinal surgeries are available for the surgical treatment. Smith-Peterson osteotomy, I'm not going into the details of those treatments because, these are more orthopedic treatments. So the prognosis, you see, let's say 1947, a person is normal. 1957, he developed early ankylosing spondylitis. 1967, marked question mark posture. 1972, he has become invalid. That means in a matter of 25 years, a person will be totally dependent and invalid. In a matter of 20 years itself, the chronic progressive systemic disease. Then finally, one important slide is there. That is the bamboo spine. Because it is bamboo spine, we have put bamboo surgery as the thank you. Now, you would have understood ankylosing spondylitis in a nutshell. So not very complicated. What are the salient points? Ankylosing spondylitis. Let us review in 5 minutes. Each one tell 1 point. Chronic systemic inflammatory progressive axial skeleton. That is one definition. What is the marker? HLA-B27 is positive in 90% of the case. But it will not rule out disease at 10%. Okay. What is the commonest joint involved? Sacroiliac joint. Peripheral joints are spared. Axial skeleton is more. Okay. What is actual pathology? Enanthesium is inflamed. Synovitis is there. Osteitis is there. Fibrosis. These are the pathology. What is the Early AS, how does it present? Early AS, early disease presentation. Pain. What? How will the pain? Pain where? Pain in the back. Is it with the exercise? Yeah. And then it is relieved by exercise or movement. It is maximum at rest in the morning, in the night. If he walks and does work, it doesn't feel. Unlike osteoarthritis. Osteoarthritis aggravated by movement, relieved by rest. Usually osteoarthritis, early osteoarthritis, no pain in the night, only daytime. Late also, of course, throughout the late presentation, what are the manifestations? Question mark posture, mobility is restricted, his functional activity is reduced. What are all the various systems involved? You tell, what are the things? Anterior uveitis, iriditis, iridocyclitis, 30% of people will have it. Response to anti-inflammatories and this one, and there is no permanent damage there. Next one. Chest, let us say.
There will be reduced expansion.
And fibrosis. And then the fibrosis, you should also differentiate from tuberculosis. Okay? And chest expansion is reduced for two reasons. Because the posterior joints are frozen and the fibrous also. Then cardiovascular.
Aortic myocarditis.
Bundle branch blocks. Aortic agitation. This can be diagnosed by echo disease. Then the inflammatory bowel disease. Bowel diseases. Then skin. Vascular type of psoriasis. Okay. And then these are the what eye, chest, heart, kidney. Amyloidosis, immunoglobulin gammopathy related chronic renal failure. And in general, blood picture will be that of chronic disease, normocytic normochromic anemia. ESR will be elevated, CRP will be elevated, inflammatory markers will be elevated. What are the tests? How do you test the mobility of the shoulder? Mobility of the lumbar spine. Shoulder test.
And finger test.
Wall occiput. Tragus. Wall occiput normally 0 is less than 50. This is more than that. Now you tell me about the test for the. He has told about this lumbar. Now tell me the test for the thorax. Chest expansion. Normally 5 centimeters, it is reduced. Take an X-ray also. Now for the next test is for the for this one, the cervical. All occiput tragus is there, and then rotation. Goniometry use. Normally 90 degrees rotation. This fellow will have less. Now, what else is there? The test, I think those are there. Intermalleolar distance. Intermalleolar distance. These are the tests. Now, how do I know whether there is inflammation or not? There are figure of 4 test, and then the pelvic compression test, and Janssen test. These tests will tell you about the sacroiliac. Okay. What is the management? General measures, no weight reduction, no smoking, of course, and then, the rest, no contact sports, regular exercises, and ordinary sports they can participate. Then you have the second one is NSAIDs, indomethacin, drug of choice, ibuprofen, diclofenac can be given. Then you have the steroids, prednisolone, 1 milligram per kilogram body weight, or hydrocodone. So can be used for short periods. Okay. Then DMRDs. What are the DMRDs available? Sulfasalazine, methotrexate. First choice sulfasalazine, methotrexate 7.5 to 20 milligrams once in a week. Always monitor when you give methotrexate, monitor liver function test, monitor the blood counts. There could be pancytopenia, there could be leukopenia, and there could be liver enzyme abnormal. Every 1 month, whenever you put them on DMRD, particularly methotrexate, you have to monitor the liver function and also the CVs. You have to monitor. Then, what else is left? Then the biologicals. Okay, adalimumab, infliximab. These are the monoclonal antibodies that you want to expect in selected case. In surgical treatments are there, yes, there are some osteotomies, Smith Peterson osteotomy, etc. Some osteotomies are there. So beyond that, the prognosis, the disease, whatever you do in our 20-25 years, the disease will be progressive and crippling. And this generally affects the people in the middle age. Osteoarthritis, later age. Rheumatoid arthritis, middle age. So this is a thing. What is the other name for this disease? Mary Stumpel disease.